name's Amy Alderman, and I'm happy to discuss with you my thoughts in regards to the paper by Dr. Fisher and his colleagues from the University of Pennsylvania that looked at risk factors associated with complications with autologous free-flap breast reconstruction. Just to give you a brief summary, this is a level 3 evidence-based study. They did a retrospective review of their prospectively maintained database, and they looked at factors associated with a major early complication and a major delayed or late setting complication with autologous breast reconstruction, specifically free flaps. The authors found some interesting findings. Number one was that major complications in the immediate setting, such as a free flap loss or thrombosis, was primarily associated with clinical decisions, and those were two. One was the type of flap used, and they found that I-gap and S-gap flaps had a higher complication rate. And the second was the recipient vessels, and when vessels had to be used that were not the IMA or the thoracodorsal, thrombosis or free flap loss increased. In regards to more of a delayed setting, major complications were associated with medical comorbidities such as COPD, diabetes, and hypertension. Not surprisingly, they found that healthcare costs increased when there was a complication. They also found an interesting association between the surgeon's years in practice and the thrombotic rate in the OR, with surgeons that had been practiced longer having a higher thrombotic rate. But what they didn't control for was the amount of resident or fellow involvement. One could easily postulate that more experienced surgeon may be more likely to allow resident or fellow involvement with the anastomosis, and that could impact outcomes. I think this paper is definitely important in regards to guiding our clinical decision making for autologous free flap breast reconstruction, and also informing patients of the risks and possible complications. I think the paper also has two important policy implications that we should consider. One is in regards to how we can try to minimize complications. It's hard. This is a very difficult patient population, but consistently there are two patient-level factors that appear to be associated with complications: nicotine use and obesity. And we see this in multiple outcomes with autologous reconstruction and also in implant-based reconstruction. There are a lot of clinical and patient-level factors that we can't control, such as the use of radiation. But these two, nicotine use and obesity, are somewhat controllable. Now, in the US, very few procedures are performed in the delayed setting, only about 10 to 12%. And this has been a big paradigm shift in the US. 20 years ago, most of our reconstructive procedures were performed in a delayed setting, but now there's a big push for an immediate, and I think that has lots of advantages. But perhaps we should take a second look and consider if we should do a delayed procedure when patients have a known risk factor that may be controllable. And if we're going to do that, we need to do better to help these patients with nicotine cessation and with weight loss, and really provide a multidisciplinary care approach to these patients to try to optimize themselves for surgery. The second policy implication is regards to potential payment reform. And what do I mean by this? Well, for years, the Obama administration has been discussing changing our reimbursement from the current system to one that is an episode-based care reimbursement. So right now, the concern in regards to our system is that we as physicians are incentivized to do more procedures. The more procedures we do, the more we get paid. And they're considering doing more of a lump sum payment so that you get paid an X amount of dollars to take care of a breast reconstruction patient. Well, I think this paper and others are important to highlight how complex these patients are. So if we look at the outcomes from this study, this is a top medical school, high volume, world-class surgeons. But if you count up all of the major and minor complications in both the short and the long term, the complication rate approaches 58%. That's no reflection of these surgeons. They're doing an amazing job. It's a reflection of how complex these patients are. We've published similar results from the Empress project that was 23 surgeons across 12 different medical centers with complication rates in the 50 to 60 percentile. So why is this important? I think it's important data for us to have in case we need to negotiate our reimbursement in the future. These are not easy patients to care for. They're complex, complication rates are high, and we need this information for future negotiations. So in summary, I would like to thank the authors for performing a very comprehensive, a very thoughtful analysis that will help all of us in clinical decision making and caring for these patients. I'd also like to commend them for their efforts to maintain a prospectively based informational system or database on these patients that consumes a large amount of time and resources. And the only thing I would like to bring up is that it would be great if the researchers would consider incorporating patient-reported outcome measures into their database so that we can look at the experience patients have, not just from a complication standpoint or a financial standpoint, but how they themselves feel about their experience, their outcomes with different types of breast reconstructions, whether it's autologous implant and different types of free flaps. Thank you very much.